Okay, everyone, happy RT week. It's Thursday. Can't believe it's Thursday already. I'm Kelly. I'm from the RTSO Leadership Committee, and I work with Steve, who's on the line, but can't be showing himself at the moment. So we're just here. We're very excited to be sharing with you today. It's a follow-up to a presentation we had earlier in the pandemic. So we have Dr. Zain Chagla and Chris with us to talk about COVID-19 myths, what we've learned so far. Just quickly before we do that, here I'm hoping you guys can see my screen. I just wanted to share with you that the winners of the awesome t-shirt competition that we're running. So you have here the shirts that did win, that you guys have all been ordering. We've sold over 300 shirts to date, which is awesome. The shirts are still for sale today, and here's the awesome design winners. So we did have one design that was redesigned by a Hamilton art student, so her shirt's up there. And then we have the Lene Cooper's shirt, as well as Freshta's shirt. So thank you to everyone who's ordered it. We look forward to seeing more pictures of the shirts as we go along. And then if you haven't had a chance to check out the RTSO website, there's lots of really exciting things happening this week, and the social media networks as well. You guys have been doing awesome jobs of getting recognized and putting pictures out there and having fun despite the current circumstances. There's also a call to action. We're asking for all RTs. So this is the executive put this forth. It's asking for all the RTs in Ontario to take an opportunity to fill out the call for action. So we're looking for petitions so that we can try and kind of prove that we need to have ultrasound included in our scope, in our controlled acts of what we do, because we do use ultrasound for many things, and we will continue to as our role evolves. So if you have an opportunity to go and do that. Also, Airwaves came out this week, which is really amazing. There's some really great stuff in there. So if you haven't had a chance to check it out, maybe go by and see. And then if you did want to order a shirt, you haven't had a chance to do that yet, $5 from every shirt does go to support Feed Ontario's COVID-19 emergency food box program. So we paired up with Toronto Teas to do that. And then we've also opened up a direct donation, which is through Canada Helps there. And that link went through your email if you're an RTSO member. And if not, feel free to email office@rtso.ca and we can send you the link, because there were some people that wanted to donate, but they didn't need another shirt. So without further ado, I'm going to introduce our speakers for today. So Dr. Chagla is an associate professor of medicine at McMaster University, and he's an infectious disease consultant at St. Joseph's Healthcare in Hamilton. He's also the co-medical director of infection control at St. Joseph's and Niagara Health System, and he's a part-time consultant to Wituik General Hospital. He's part of the provincial response. He's also been part of Ontario health guidelines and personal protective equipment and treatment of COVID-19. And I know that us here, we're very fortunate to have him because he's been helping to keep us safe. The other person that's been on the ground is Chris, and he's an infection prevention and control nurse here at St. Joe's. Throughout this pandemic, he's been working alongside the RTs as the frontline IPAC resource for various areas, such as the emergency department, outpatient pulmonary rehab, pulmonary diagnostic, COVID unit, and urgent care. So he and I have been spending a lot of time together because he's pretty much everywhere RTs are. He's assisted the RTSO on various initiatives that we've had by giving us some IPAC insight, and he's participated in the town halls at the beginning of the pandemic to help kind of give us a sense of what we were dealing with. So we're very excited to have both of them here with us today, and I'm going to hopefully now successfully transfer it over to Zain so he can share his screen, and let's see how this goes.
All right, that looks like I'm somewhere there. Looks like I'm there. I lost my mouse somewhere, but oh yeah, there we go. Show my screen. That looks okay.
Awesome. I'm going to turn myself off and they can see your beautiful face.
Yeah, let's turn the webcam. I think Chris is first here, but thanks everyone. There's Chris. Thanks everyone for participating. I think we're both happy to be here, and happy RRT week too. I know everyone appreciates the work that the RT group has done during this difficult time, and also becoming thought leaders as well as technical experts for our hospitals that are going through significant changes with COVID-19. So we're going to go through a little bit today and divide it between myself and Chris. So a little bit about an epidemiology update, and really going through some of the data around fomites, which I really think need to probably be re-emphasized for people as some of the hygiene theater is getting a little bit out of control. We'll talk a little bit about the new CDC guidance and aerosols, because I think that's one of the major things that's coming up that's causing some controversy. We'll talk a little bit about some of the data around some of the AGMPs and more data coming out suggesting, even though that we're going to consider them still AGMPs, that they probably aren't as high risk as we think. Talk a little bit about the healthcare worker experience globally through the first wave and some of the diagnostic and therapeutic updates. And with 35 slides, hopefully leaving a good amount of time just to answer some questions too. So I'll pass it over to Chris here.
Sure, thanks, Zain. Hello, everyone. And yeah, so I guess we can just maybe set the stage going over, you know, an epidemiology update to see kind of where we are from a global level down to the Ontario level in terms of COVID-19. So starting at the top, right now we're sitting at 44.5 million cases, so quite a few, with most regions experiencing increases in cases. As you can see in the diagram here, the Americas, Europe, Eastern Mediterranean areas are all experiencing increases relative to where they were before. Leading the way, US, the United States has 8.8 million cases, India is coming in around 8 million, and Brazil 5.5 million. Across the globe, we're at 1.18 million deaths. So absolutely a huge impact it's had on the entire world. In terms of deaths, we saw a really sharp spike in deaths in the first wave, and it's kind of plateaued from there with small, you know, ups and downs as we go on here. Yeah, Zain, if you don't mind going to the next slide there. So moving on to Canada and next as well. So here's where we are with cases in Canada. No worries. So as of today's update, we're about 225,000 cases across Canada, and as you can see, two clear waves here. Cases are increasing with most provinces experiencing some level of growth, and deaths are also on the rise. We just hit about 10,000 deaths across the country, so definitely significant. Although the rate of death increase is slower in the second wave compared to the first. Next slide, Zain, please. So this shows the rate of cases per province. So as you can see, there's after accounting for population size, there's definite differences in how the provinces are faring across Canada. Quebec, Alberta, and Ontario with the highest rate per capita. And next, please. And then when we kind of break it down by age and sex, you'll see some interesting trends here as well. As we moved into the second wave, you've probably heard there was a sharp increase in cases among the younger folks, aged 20 to 39, and you can see that reflected here in the graph. They're kind of the first group to kind of spike up, but as you can see, it's spilling over into other age groups as well. Yeah, absolutely. So next, we can move on to Ontario. So total cases right now, as of this morning, 73,819. Again, increases, but there's some regional differences we'll take a look at a little bit later. As you can see, I like how this graph kind of outlines the where people are picking up COVID. And at the start, the first wave, a lot of the cases we came across were linked to close contacts and outbreaks. And as we go forward, you can kind of see a shift on when we're looking provincially to more people reporting no known contact. So they're not exactly sure where it's coming from. And this is kind of tricky because if we don't have a sense of where they're picking it up, it's harder to control. So it's really important to do really thorough backward contact tracing to find these clusters where these cases are emerging from. In terms of deaths in Ontario, we're at 3,118. And again, kind of a slow increase in deaths in the province. Maybe, do you mind going forward, Zain? I'd like to highlight too how we're doing with testing. There's been lots of changes to testing criteria, who we're aiming to test over time, as well as there was a period of time where there was a fairly substantial backlog as well in terms of we're testing more people, but there was a hard time turning those around on the lab side. So as you can see, early October, we kind of shifted to appointment-based testing in Ontario. So our volumes have gone down a bit, and we're probably more targeting those with a higher probability of being cases. So having symptoms or known contact, and kind of from my perspective, expectedly the percent positivity is raising slightly, and that comes along with transmission and also testing more targeted. And do you mind going forward, Zain? Again, I like to look at the ages here as well. As you can see, the first wave, there's a huge spike in the rate of cases among the older adults in Ontario, and this was paired with outbreaks in long-term care settings, congregate settings. And as we kind of move forward into the second wave, the younger age groups started to increase first, and but as you can see, the predicted spillover into the other age groups is seen here in Ontario as well. And then we'll take a look at the next slide here. As you can see, the spread in Ontario isn't the same across all our health units. There's a lot of clusters of cases popping up in Toronto, Halton, Peel, York, Ottawa area, and you can see in other areas they're experiencing a bit less of a burden. So it's important when thinking about our interventions to stop the spread. It's important to be targeted to the areas where they're occurring geographically, and also the settings in which transmission is happening. So that's kind of a high-level overview of cases across the globe down to Ontario. So as I mentioned, we want to touch on a few areas of interest, one being fomites. And I find there's been a really interesting progression in our understanding of spread through surfaces and through objects since the start of the pandemic. So you may have seen this picture float around. It went around quite a bit at the start of COVID, where basically there was a study where they tested how long COVID would survive in lab-controlled settings on various surfaces to try to figure out, can COVID spread on surfaces? Do we need to be worried about this? And this kind of influenced our understanding at the start back in April, where certain surfaces like plastic, steel, cardboard, they did have survivability of the SARS-CoV-2 virus. For, if you look at plastic, we're up at 80 hours. So this kind of influenced our understanding of the risk. But as we move forward, Zain, thanks. There was a bit of a shift in opinion. There was more evidence coming out around maybe this isn't such a risk that we thought it was at the start. There were multiple studies, but there wasn't really a strong real-world evidence coming out that transmission was possible through this route. So in May, there's a good study where an emergency department and some like a sub-intensive care ward were swabbed environmentally. So they swabbed some PPE, they swabbed some surfaces. Out of all their swabs, only 2 came back positive. One was on the CPAP helmet. When and it was an RNA culture essentially, so it picked up the genetic material. When they tried to find cytopathic effects, so the ability for it to replicate and potentially cause disease, they could not find it. So this is kind of a red flag saying, oh, maybe we don't need to be as concerned. And as we move forward in time, there were further studies. So in July, again, an environmental study where it was actually a COVID-19 unit in Italy that was hit quite hard. This unit was full at the time. They swabbed common areas, outside patient rooms, nursing stations, kitchenettes, that kind of thing. And out of all their swabbing, none of these swabs actually came back positive for the RNA. Which when I think about this, I think all hospitals have routine cleaning, and it's pretty strong evidence that whatever they were doing in terms of their cleaning practices there, they were effective in reducing contamination of the environment. And as we move forward, this study was one I like to go to as well. Environmental samples from COVID units and also quarantine hotels, so places where they allow people who had COVID to stay and go, be quarantined from their loved ones. They took environmental samples from those areas. 52.7% of the samples on the actual COVID unit came back positive for RNA. And 38% of the samples at the quarantine hotel were also positive. But again, this doesn't necessarily translate to actual ability to cause disease. So what they did was they did some tissue cultures, and they found that none of these isolates actually were able to produce infectious titers of SARS-CoV-2. So essentially, the when we can't culture them, it suggests the risk and feasibility of this transmission route could be low. Yeah, I guess in summary, what does this mean? We went through a lot of months of trying to understand this, and where we are right now is there's a lack of strong evidence supporting the feasibility of transmission happening in actual real life settings, and the lab and real life, of course, are very different settings. And even if this was to happen theoretically, there's a huge chain of events that would need to occur for it to actually be successful. So you need to have enough virus on the surface. You need to, contact it within a short period of time. The conditions, so the humidity, the temperature would need to be supportive of it surviving on that surface. And then you need to, it needs to get into your body somehow. It can't get in through your hands, so it needs to, get in your eyes, nose, mouth, that kind of way. So everything would have to line up quite well for this route to work. So I'd like to also kind of reinforce hand hygiene and routine cleaning of the high touch surfaces are important as ever. If there is contamination of the environment, this routine cleaning will take care of it, and our hand hygiene is important. And I like to just throw in there, not just for COVID, for all IPAC related things, we want to be washing our hands very, very well. So a little plug for non-COVID IPAC. So as we go into, I know aerosol transmission, airborne transmission has been a really hot topic since the start of COVID. It basically comes from a spot where we want to be protected, right? We want to have the correct interventions in place so we're not put at additional risk. There's been lots of discussion around the terminology. Is it airborne transmission? Is it aerosol transmission? And I like to point out that often we're probably talking about the same thing, but different disciplines use different words. So in IPAC and public health, when we say airborne transmission, we think of something like TB, which spreads quite efficiently and is suspended in the air for long periods of time and can travel good distances and cause transmission. But aerosol science takes a more, I guess, like literal and full disclaimer, I'm an non-aerosol scientist, so I could be getting this wrong, but essentially if things are traveling through the air at all, airborne is kind of a word used to describe that. So at the end of the day, I think we're talking about the same thing when we're talking about aerosol or airborne transmission related to COVID-19. There was an update recently that came out through the CDC in the States that was essentially acknowledging the possibility of some component of airborne or aerosol transmission of COVID-19 under certain circumstances. In Canada, the Public Health Agency of Canada, Public Health Ontario still essentially focus on the droplet component, but I just kind of want to go over what this means and kind of some background around it. So how it relates to COVID-19. So the concept is there's these small aerosols that could be produced by certain procedures. So Zain will go into the aerosol generating medical procedures up next. And possibly certain activities that are not considered AGMPs can create these small droplets that may be able to be suspended in the air for short periods of time under, I want to stress certain circumstances, and I'll go into those circumstances in the next slide, but there's still a lot we don't understand, and I've kind of outlined some questions there below, the conditions that contribute to it, how frequently does this transmission route occur, and such. So maybe we'll move on to the next slide. So I want to touch on transmission efficiency really quickly. So airborne aerosol transmission route, it doesn't mean all pathogens transmit efficiently this way. So I talked about TB earlier, chickenpox, primary chickenpox, disseminated shingles, that kind of stuff, they can efficiently spread through the airborne route. COVID-19, it doesn't look like it's terribly efficient. It may be possible, like I mentioned, but I don't think that the predominant way that COVID-19 is spreading in our communities. We would have likely seen much higher, attack rates across the globe if this was an efficient spread. So like household attack rates were quite low, and if this was airborne in the house, we'd expect a much higher proportion of families probably getting infected. But when could it possibly happen? And I think that the key here is thinking about our environment. So enclosed spaces, prolonged time, prolonged exposure, and spaces with inadequate ventilation. I think ventilation is kind of the key here. And if all those kind of line up, there could be some component of COVID-19 transmission through the aerosol route. We can go to the next slide there. So I guess what you probably want to know is, what does this mean for us? I want to reinforce that likely under most conditions, it's predominantly droplet spread, but under certain conditions, aerosol transmission might be important. So you may have heard this concept of hierarchy of controls, and it's the way we reduce the risk of many things, but in infection control, we reduce the risk of transmission through looking at this hierarchy. And we have these high-level controls that most people don't see, but they're kind of working in the background. So our hospital ventilation, our air exchanges, that kind of thing, are kind of these higher-level controls, which are actually a bit more effective in terms of reducing transmission risk compared to the lowest level of controls, which is PPE. Our personal protective equipment, while it is protective, it's kind of like the last ditch effort to prevent transmission. So within our healthcare organizations, we have ventilation, we have education, we have policies in place to reduce the risk to healthcare staff. So those are kind of happening all the time. And then we make choices about how we engage with these patients. So if we're doing aerosol generating medical procedures on someone with suspect or confirmed COVID, we want to be in a space with high air exchange. So whether that's a HEPA filter or like here at St. Joe's, a negative pressure room if we have them available. And then our choice of PPE. So N95 for those high risk kind of aerosol generating medical procedures is recommended. That said, I think on the community level and in non-AGMP settings, there's a lot of things that kind of contribute to reducing the risk of aerosol transmission, and that's our universal masking, it's our distancing, that kind of stuff. And then thinking about the RTs that are in the community care, going to people's homes, it's a bit different in terms of the control we have over that environment. So, consider crowding in rooms when you're caring for these patients, ventilation when able, as well as masking and our choice of masks depending on what we're doing in the home is important. So, Zain, feel free to add anything there, but that's pretty much what I had.
No, yeah, thank you. So yeah, I mean, I think, again, these terms are getting mixed up, I think, by healthcare settings, by aerosol scientists. There's, it seems like there's a dichotomy on each side. And the reality of things is that, there are settings where this may be a form of transmission. There are some assumptions made about the patient to actually do that transmission. But in the global experience, and they gave multiple meta-analysis of contact tracing studies around the world, we see this attack rate of 15 to 20% repeatedly amongst household contacts and much less in people that are outside of the household. That's balanced against, yes, these events do happen. And I think us in Hamilton, I think we've been dealing with one recently that made the news quite a bit, where this may have played a role in terms of that transmission. So I'm going to move on and contrast here a little bit about the more definitive aerosol generating medical procedures. Just to kind of go through some newer evidence, I guess, that will, that puts even a little bit of this in question. And so we have this, list. I think it's accepted by Public Health Ontario. It's fairly similar to lists in other provinces, really talking about intubation, extubation, tracheostomies, bronchoscopies, respiratory surgeries, postmortem surgeries, including the high-speed devices in the respiratory tract, dental procedures, BiPAP and CPAP, high flow and nebulized, induction of sputum with nebulized saline. So, these are generally accepted in that sense. But I think, these are based on historical data, particularly around the SARS-1 outbreak and meta-analyses of infections as related to healthcare workers in that outbreak, but really haven't been looked at again from this critical aerosol science eye that now seems to be coming to light. So I'm just going to bring up a couple of papers that they're not going to change practice, but just really rethinking about, are these really truly AGMPs, or they're historical AGMPs where in the context of our patients may not be in that sense. So this was an interesting study that was done in the Journal of Anesthesiology that was published a couple of weeks ago, where they did this essential optical particle size monitoring after an intubation and extubation in a controlled room. They put a particle sizer, and you can see this guy holding the funnel, which is essentially what the particle sizer looked like. And again, did the intubation and extubation. They did do a measurement, kind of just baseline to get the tear of what the general aerosol content of the room was. And they actually compared it to just a volitional cough in terms of the baseline of a non-aerosol generating procedure, what a cough looks like. And again, looking at intubation and extubation. So you can see here the volitional cough generated a number of particles, the fairly high concentrated particles of the number of experiments they did with the volitional cough 38, about 418 on average. It's interesting, the tracheal intubation actually just didn't generate a significant number of particles. Even when you look at extubation, including a cough, you did generate a slightly higher number of particles. The particle diameters, as you see, do vary. The volitional cough tends to produce some of the higher size particle, which is where we don't consider it an aerosol generating medical procedure, whereas you do see some of the particle diameters going down in the extubation related cough. But again, the concentrations actually seem to be relatively smaller as compared to just a volitional cough. This was done in a very controlled setting, a controlled intubation and extubation in negative pressure room. And so, you take it with a grain of salt. This is probably not going to be the patient you're intubating on the ward who's going through a crash intubation, or the patient that's coughing quite a bit while you're doing the intubation. But just, a little bit of food for thought, suggesting that potentially these events done in a very controlled manner aren't as dangerous as we seem. Again, I think most of us do believe that they're aerosol generating in the context of a COVID-19 patient. But I think of the last time I was here presenting that data around the first kind of couple of cohorts of people where they were completely missed, despite going through a huge amount of aerosol generation and very little downstream infection. And even in those cases, half those people weren't even wearing masks. So just again, food for thought in that context. This was another study looking at high flow oxygen, which has been one of these things. Initially, in the clinical management of COVID-19, there was a push to put people on the ventilator relatively quickly as they were developing acute respiratory distress syndrome. As we've learned, I think that may have actually been more deleterious to our patients than helpful. And that the aerosol content here could be well dealt with controls and PPE in the right patient, rather than necessarily denying patients optimal therapy, especially ones that involve ventilation, long stay weaning, all that stuff. So this was again another study looking at high flow nasal cannula, as compared to simple mask, a non-rebreathing mask, Venturi mask at 0.4 and 0.35 at different flow rates. You can see kind of here, they're just looking at dispersion distance of the particles as we talk about kind of whether or not that aerosolization means that the entire room is going to be contaminated in a significant amount. And similarly, you actually see when the lower flow rates, you see more dispersion distance of droplets as compared to some of the higher flow oxygen devices. I think we run into this problem sometimes in the patients that are getting aerosol generating medical procedures in rooms that aren't necessarily equipped for it, especially in some of the more regional hospitals where they don't have proper N95 rooms, airborne rooms, and then negative pressure rooms or HEPA filters. But again, it seems to be that most of the dispersion, and if this was using an exhaled smoke model, was relatively close to the patient with the higher flows as compared to the low flow oxygen models. This was another study using a fairly similar model, interestingly looking at all modes of non-invasive ventilation, so not just high flow nasal cannula, but non-invasive positive pressure ventilation as well. And you can see here again the particle concentrations again of person on room air nasal cannula at 4 liters, at face mac 15, high flow at 10, high flow at 30, high flow at 50, and then BiPAP 12 and 5 and 20 on 10, you can see the particle concentrations associated with even things like normal breathing, talking, deep breathing, coughing, are relatively preserved across all of the spectrum here. Even the geometric mean of the particles, again, tends to be favoring the higher sized particles in that sense, rather than the less than 0.5, where we start talking, or sorry, yeah, the smaller diameters, where we start talking about, the true aerosols. Again, this is interesting food for thought. I don't think this changes our precautions by any means. But I think with the things that we may have classified as high risk, really, and in the grand context, in clinical high risk, from an aerosol science standpoint, might not be as high risk as we think. And again, this is part of the issues with going back to what happened with the original SARS virus. So that brings the question of how healthcare workers are getting infected. As we're talking about, patients with COVID-19 who the infection may be missed, or these aerosol generating medical procedures who are really that aerosol generating. So why are healthcare workers coming down with COVID-19? I think we heard a lot about the beginning about people that were young, healthy, a huge amount of workers in China being infected, and certainly triggered our alarm around a number of mechanisms of spread and what happens in hospitals. It's interesting, even that China data, when it was re-looked at down the line, so this is a study done of a number of individuals from China, and the deaths from there. Realistically, once the appropriate PPE was integrated, the risk of death in those individuals actually went down significantly. Here they only saw, actually, in this case, the first study, that only of the amount of people that were showing up, they were very less front facing than people had thought. So this was actually a further analysis done of that cohort. Again, this was in Wuhan, China, at the epicenter. There were 110 of 9,700 healthcare workers in that tertiary care hospital in Wuhan that were infected. Interestingly, the number of frontline workers, and again, this is in the context of more available personal protective equipment and better diagnostics for those patients. The percentage of frontline healthcare workers were less than the non-frontline workers. And this is kind of where we started seeing this first trend of the more dangerous people to healthcare workers were other healthcare workers, and as well unrecognized patients, which I think we've done a better job at trying to identify more appropriately. This was replicated in a number of other contexts. So this was a study done in Newcastle, England, during 20 days of March, kind of at the beginning of their, or when they were within the midst of their first wave. They had identified 240 staff that tested positive, which really did follow the growth of the pandemic at the time. It grew as weeks grew. Interestingly, again, when they tried to analyze some of the staff in terms of those that were front-facing versus partially front-facing versus non-front facing, so administrative staff, there really wasn't a difference in terms of the rate of infection in these individuals. So it didn't necessarily depend on where you worked and COVID-19 patients you were facing, which is, again, some of this interesting signal towards other healthcare workers and home settings being the context of where a number of healthcare workers are getting COVID-19. And the fact that these were one of the few institutions that were open and kind of at capacity with healthcare workers during the first wave of COVID-19 during the lockdowns. This is a similar study that was done in the Netherlands that was published in July. And again, a cross-sectional study amongst 2 sites. They actually had similar precautions to Canada in terms of PPE for COVID-19 patients. They invited any staff that wanted to get tested. There was about 96 that tested positive. This was both PCR and this was PCR-based testing, sorry. So 96 tested positive. Again, a good amount were frontline, and 20% went back of the line. This may have been biased by the fact that the people that actually came to be invited for testing or were interested in getting tested tended to be the frontline people, as they obviously thought their risk was higher. And again, if you look at the survey, about 3% of those frontline people had contact with a positive patient, whereas 30% had contact with a suspect colleague or a household member with symptoms. And again, it really does define that risk associated with our colleagues more than just our patients. Interestingly, when they took the samples and did whole genome sequencing, they saw multiple community transfers coming into the healthcare system without necessarily major amplification events occurring within the healthcare system, really suggesting, again, the virus comes in through our community roles and then may transfer within the hospital in small amounts, rather than us having big amplification events in the hospital and then seeding the communities with it. This is an antibody screening project that was done in Belgium. Again, fairly similar, that staff were invited. About 197 chose to get their serologies done. About 6.4% of the staff were actually positive antibody-wise. Looked back at them, and again, in terms of the risks, exposure to patients working during the lockdown and exposure to coworkers, interestingly, are associated with no difference in COVID-19 positivity. But again, the big thing that saw that the risk of COVID-19 positivity was a report of a household or contact that was positive. It's interesting too, going back to these cases that had that tested positive on antibody, even though these were people that were asymptomatic in the sense that they were working and screened negative at the door, they were actually, on retrospect, a lot of them were actually symptomatic. And in fact, a good number actually had anosmia, which was, as we know, one of the unique symptoms to this disease. So again, even the screening processes, as good as they are, unfortunately do not compensate for everything. And it's just an interesting subset of people that really are really truly positive, that just minimize their symptoms. Quickly moving on to just diagnostic updates. We now have 3 big platforms available in Canada. The first is the PCR-based platform, which we've been using obviously since the beginning, which is how we've been doing the bulk of our testing. About a month ago, the government released the Abbott ID Now, which is now starting to trickle into Canada. This is a toaster-sized device that does a molecular reaction that's a little bit different than PCR. You still have to process a sample. Acceptable samples are nasal, oral, or nasal, nasopharyngeal, or throat, so that there is some ability to test some less invasive specimens. This does require still some operator dependence, but the 15-minute test results in a relatively small footprint make it a useful device, and some looks now from the provincial government at rolling this out into long-term care facilities, going into outbreaks and other test projects, as well as remote communities. Sensitivity of the device is still not as perfect as compared to PCR. It's about 82 to 85% sensitive. The specificity is quite good, greater than 95%. So again, the use cases for these devices are going to have to be in areas where we can accept some of that dependence in terms of operating characteristics. And then finally, we do have rapid antigen testing, which is the device I think people have been most wanting on the market. The Abbott PanBio is the test that's approved in Canada currently. This has about a 70% sensitivity, but 95% specificity. It looks like a pregnancy test. The only issue now is that the only approved sample currently is a nasopharyngeal swab that is provider, usually, I don't know many people that can do a nasopharyngeal swab on themselves. It's a provider given, but it has a very small footprint. Again, essentially a vial that you drip onto a pregnancy test. and wait for it to resolve within 15 to 20 minutes. So again, a lot of looks here in terms of some of the serial testing that's going on in long-term care, whether or not this can be the device that actually replaces it, and saving PCR for more symptomatic patients where sensitivities need to be a bit better. In terms of therapeutic options, I think most of us know the standard of care now of COVID-19 patients who require oxygen is dexamethasone. So this was the recovery trial, which is an incredible trial done by the UK group, where they enrolled patients into multiple domains, has really informed our practice. This was the Kaplan-Meier curves essentially showing a mortality benefit to patients that got dexamethasone, which was impressive, particularly in the group that was mechanically ventilated, which given the other clinical trials to date has been a very hard target to fix. The number needed to treat in the dexamethasone arm in invasive mechanical ventilation is 6. And for patients requiring oxygen, it's still a mortality benefit with the number needed to treat of about 25. There was no difference seen, and in fact, a little trend to a harm in the group that had no oxygen, where the presumed mechanism here is that there's not a significant amount of inflammation that's driving their COVID-19. So, again, the recommendations now are anyone who's oxygenated in hospital get dexamethasone 6 milligrams for 10 days. The other drug that I think has gotten a lot of press recently is Remdezavir. Remdezavir is an antiviral that targets the viral RNA polymerase. There's been really 2 big trials that have had conflicting results that are now being resolved in terms of purchasing, as well as a media campaign and perhaps some more insidious gains. So the ACT-1 trial, which was done in the United States amongst a number of other centers, that was sponsored by the National Institute of Allergy and Infectious Disease, looked at Remdezavir in patients who were admitted to hospital. The initial analysis came out with the DSMB review in April. And this was, as many recall, where Anthony Fauci was in the White House saying that there was a standard of care finally for COVID-19. The 28-day data, and remember, so they had enrolled most of the trial when they did their first DSMB. The 28-day data came out 130 days later. It did not show a mortality benefit, but a trend towards such, suggesting that perhaps they had underpowered the trial. There were about 250 or 260 in each arm. But there was a trend to at least decreased hospitalization from 15 days to 11 days in those who were on low flow O2. There was no benefit seen in those who were critically ill, particularly those on ventilators and those who required non-invasive ventilation and ECMO. The Solidarity data, which we've been privileged to actually participate in, is a World Health Organization trial that really aimed to consolidate all of the clinical trials that are being done in multiple countries on therapeutics to generate the largest data set possible. The interim analysis of the first wave of the Solidarity data, which was a 10,000 patient open label data set for Remdesivir, suggested no benefit to hospitalization, ventilation, or death, which really has thrown a lot of shade at what the benefits of Remdesivir are that were suggested in ACT-1. There was another trial that was actually done in Wuhan prior to this that was very small and in fact had to stop enrolling because their COVID situation got so much better, showed no benefit either. And so many skeptics are saying the ACT-1 data may be the one that is a bit made up. I think, unfortunately, Canada bought a significant amount of drug prior to the Solidarity data coming out. Although if you make the argument that it at least decreases hospitalizations by a couple of days, given the PPE requirements and the concern of patients being in hospital with COVID-19, it might be cost neutral at this point at $3,000 a course, but by no means is the miracle drug, despite what Donald Trump says. And then finally, what hasn't worked, hydroxychloroquine. There's been trials looking at early treatment, late treatment, hospitalized patients, post-exposure and pre-exposure prophylaxis, all of which have shown no benefit to hydroxychloroquine. There was a signal in the early treatment group of slightly milder disease in people that got hydroxychloroquine, milder symptoms, but not really statistically significant. Lopinavir, ritonavir had 2 clinical trials, one the Solidarity trial and one another trial that was done in China during the initial wave that showed no benefit. Interferon beta had 1 clinical trial that was done in Hong Kong suggesting benefit when given in mild patients early in their disease, whereas Solidarity did suggest no benefit in the large group that was analyzed, so potentially this was the definitive trial to say no. And then tocilizumab, which we did have at St. Joe's for a clinical trial, is very unclear. This is a fairly immunosuppressive molecule, and so we are very nervous using it, obviously, in critically ill patients. There may be a slight benefit to hospitalization and ventilation days, but certainly no major benefit in terms of mortality. The data is starting to trickle out about this, and again, it seems like it's going to be fairly underwhelming. What's in the pipeline? So monoclonal antibodies, unfortunately, Eli Lilly trial showed no benefit. There was a trial actually that was released last night of another monoclonal product where it's very controversial if it's showing any benefit. They did it in fairly mild individuals who were outpatients. It did seem to reduce the amount of hospitalization of those individuals, but may have decreased the viral load, although there's some concerns that may have just been data mining more than anything else. We have convalescent plasma, which has shown some effect in the United States, another big trial that was done in India that showed minimal effects. And we are currently enrolling across Canada for the Concord 1 trial, which should hopefully bring the answer to this finally. We have other immunomodulatories and the experimental compounds. There are now trials ongoing for Remdezavir given early, as the company really wants to see this drug being used and is making the argument that we're giving it way too late. Although, hospitalization, first day one of hospital is often pragmatically when we give it. And then some data around inhaled therapy, Remdesivir, which is also being considered as an inhaled drug, as well as interferon-based therapy inhaled, which showed some success, although that was a press release by a company, so it's unclear whether or not there's truly going to be any benefit from this. And with that, it is about 15 minutes left for questions, which I'm happy to take.
Okay, there are a few questions that have come in, Zain.
Awesome.
And Chris. So the first one is from Frank Fiorenza, and it's, oh, he's just moved down. Hang on. There we go.
Yeah.
As there are many more patients on low flow oxygen delivery versus high flow nasal flow cannula or NIV, as it is identified that NIV, high flow nasal cannula, are not as much of a risk and typically done in ICU setting, negative pressure room versus the wards. Do you think more precautions should be implemented with patients on low flow oxygen?
It's a good question. I mean, I think the data still suggests, and again, some of this data suggesting really that the risk, like, I guess you're looking at the glass full, glass empty, right? So, glass full is actually high flow is probably not as much an aerosol risk as we think, versus glass empty is, actually low flow is more of an aerosol issue than that. I mean, I think we have the experience of lots of patients. We have this experience, obviously patients who are hospitalized, we're not seeing it in healthcare workers that they're being infected by those patients. They're being infected by their coworkers and unidentified patients. That I really do think that the current level of precautions that we have for low flow oxygen are fairly reasonable. Our rooms still have some degree of ventilation and air exchanges as well. And so, I don't think a need for more masking or a need for more precautions are there, simply because, again, most of our patients are on low flow oxygen that are staying in hospital. And so we've been able to care for them pretty reasonably with the precautions that we have.
That's awesome. Another question that's here is from Anita, and she's out, and I believe Aurelia. A lot of RTs have been trying to figure out why ventilator disconnect has not been an AGMP list. Is there any thoughts to share as to why this would be?
Yeah, the discussions at the provincial side was that these would typically be very short events. Some of these ventilators do have filters too. And so, the amount of aerosol generation would be fairly minimal in the grand context. Different organizations have taken different approaches to this. Some have gone on the basis of following the letter of the law, whereas others have said, we're going to accept that this is a potential risk in that sense. It really depends on the setup and how long things are recognized when the pop-offs happen and that type of thing. So, I think in again, knowing what we know about aerosols, particularly in that sense, if it's a very short pop-off, you're probably generating a very minimal amount of aerosols. But if there truly are issues where the ventilators, cut circuit for 5, 10, 15 minutes, and there's definitely a problem. There's other problems there as well. If the ventilator's off for that amount of time, but yeah, then we might, then thinking about precautions in that sense might be a reasonable option. Again, that's where kind of individual point of care risk assessments come about.
Thanks, that's great. Another one here, great presentation. This is from Gino in Kitchener. If SARS-CoV-1 back in 2003 was treated as airborne, do you think the only reason they are not committing to SARS-CoV-2 being airborne is due to the global shortage of PPE, specifically N95 masks?
Yeah, and I think the precautionary principle was applied to SARS-1 because we didn't know what it was. It was the first coronavirus pandemic that we saw. I think, it's interesting. If you look at the retrospective data of where people were actually getting infected, and especially the nursing studies using masks versus N95 masks versus surgical masks, it was really associated strongly with those aerosol generating medical procedures and not as much associated with routine care of patients. Now, the answer isn't answered yet. And I think, we are currently enrolling across Hamilton, at St. Mike's and a number of other centers in Niagara in a Sentinel N95 versus medical mask study to finally answer this question, as I think all we're looking at is basis of observational data from left and right from different places without any true balance. So, I get where the kind of question is coming from. I think we've enrolled about 120 of our 500 target across the country. So hopefully we'll have a definitive answer to this really pragmatically for that patient. Does an N95 make a difference for a non-aerosol generating patient?
I can't wait to see that. That's great. Mm-hmm. The next question is from Megan, and I believe she's in Oakville or thereabout. Is the higher rate of transmission within the community versus the hospital due to increased viral load in shared spaces and increased time spent in those spaces?
Yeah, it's a good question. And I think, we do know the viral kinetics of people, particularly in their first 2 to 3 days of infection symptoms, and the 1 day prior is kind of where that peak infectivity is. And so, to me, or at least to other people, it's, that patient that gets admitted day 5 to the hospital is very different than necessarily the patient that's, day 0 in their own facilities or at home or in one of these kind of super spreading scenarios. So yeah, there is a fundamental difference. I will say though, I think there is an argument to be made that, well, we're not putting the right precautions on, or the precautions were fine in hospital because we're dealing with patients that are, not as infectious at that point. And they're 5 days typically into their symptom onset, so their kind of viral loads are starting to come down. We've been auditing our cycle threshold, so kind of an aggregate or a secondary measure of infectivity. They're really low in the patients that are still showing up to hospital. We're talking, to say someone's non-infectious, we're kind of talking 30 to 35 range. For most of the patients that are diagnosed first day in hospital or coming from the community or swabbed when they show up to hospital, we're still seeing cycle thresholds less than 20, suggesting this is legitimate infectious spread. So yeah, it's not a perfect answer. There is certainly a factor of those patients at the earliest part of their infection being most infectious. But still, patients who end up in hospital, especially in the first few days, are still really, really infectious.
That's really helpful, thank you. Our clinical scientist has put a question, and I actually appreciate this question. She says, thank you for the talk. Can you explain the sensitivity and specificity of diagnostic testing in plain language, you can't see me on my camera on, but I've got my quotations. Related to this, are two-stage diagnostic tests done in certain circumstances? For example, in negative in rapid antigen testing, would a second PCR and then a dots?
Yeah, no,
I'm
I
not sure.
agree with you practically. So I mean, this is the problem is these products are coming to the market literally now. Like they've been distributed across Canada in this last week. So you're right. If we have a highly sensitive test, if we have a highly specific test, the rule out value is there, right? If we have a highly specific test that rules in the infection very well, where you have a highly sensitive test, the rule out is there in that sense. So if you have a test which has lower sensitivity, your ability to rule out COVID is really dependent on the population you do it and their pretest probability. If I have a patient that has cough and fever that's showing up to the emergency room and their rapid test is negative, I'm not going to believe that result because their pretest probability is particularly high. And we know these tests, as their sensitivity goes down, miss some positives that are truly positives. If I have a patient or a staff member who's feeling completely well in the long-term care facility that has a negative rapid test as part of a surveillance strategy, that's a completely different thing in the sense that, my expectation of that person having COVID-19, if there's no COVID-19 transmitting in that care facility, is going to be relatively low. That negative test probably means that it is truly a negative test in that context. So, these are the value judgments that are ongoing now. If we're going to use these rapid tests for true diagnostics of symptomatic individuals, where there is some proposal to be doing that in some of the northern areas and remote areas of Ontario, then they will have to be tagged on to a PCR test. It's just to buy some extra time to do at least an initial test on site and then send the tests off site where we see delays of 2 to 4 days to get results. If these tests are going to be used in the context of people that actually have a low pretest probability of having COVID-19, so as part of surveillance, going into schools, testing healthcare workers who are asymptomatic, then yes, I think we can rely on the results a bit more reliably. And then obviously, even in that context, positive tests would still probably have to be followed up with PCR along with isolation to confirm the results or just to rule out a false positive in that context.
Thank you, that's helpful. The last one's a pretty big question with a few words, and I see we have a few minutes left. So, Chris, you're smiling because, yeah, I'm looking at you. They're asking, this is coming from Christian, and he's asking your opinion on PFT testing. And that's just the question. What's your opinion on PFT testing? So I guess the thought is maybe let's say the top 3 or 4 considerations regarding doing PFT testing at this time.
Yeah, sure. So I think that focusing on the population and kind of your community epidemiology is important. Thinking about what's happening outside the hospital or your clinic, and kind of what Zain was talking about, the pre-test likelihood of someone coming in having COVID. I think generally, like for PFTs, I think our general concepts of distancing. I know some centers have physical barriers. Our PPE use or ventilation in that space are all important to consider within your testing center. And I know different centers have different capabilities related to that. But yeah, I think those are all really important considerations. Or Zain, do you have anything to add to that?
Yeah. I mean, I think there's no right answer, right? Like, I think we can go through what our PFT labs and say what we think our level of precautions and what our epidemiology is and what our probability of someone asymptomatically walking into COVID is and what that risk would be downstream from the PFT procedures. I think the one thing that's been accepted is that induced sputum is probably an AGMP. As part of that, but for everything else, I think it's individual context in that sense, based on again all of this in that context.
Thank you. And I will add that the Tony Kajner under the leadership committee does have a pulmonary diagnostic working group, and they have put forth some guidelines from the RTSO for consideration as well. So I know he's also working on a webinar. So we've now hit 1 o'clock. So I do want to thank you both for taking the time to share with us on RT Week. And I want to say happy RT Week to everybody. And I hope that you're all having a great week. Please do check out the RTSO website to see all the great things that are happening. And if there's any unanswered questions that are coming through, I'll be happy to forward them forth to get answers for you. So take care of everything that you're doing. Keep doing a great job. And yeah, bye everybody. You can't see me, but there you go.
Bye.
Thanks, bye.